So I'm John James. Good afternoon to you all. I'm going to be talking to you today about reimagining sickle cell disorder. We call it sickle cell disorder, and I'm going to say more a bit later about sickle cell, but mainly doctors and others call it sickle cell disease. But I'll explain why we call it sickle cell disorder a bit later on. So I'm John, and the reference to the Windrush Empire Windrush ship there is that I am from the generation of Windrush. My parents came to this country in the 50s, and then they sent for me. In those days, they would leave the children, come and settle, and then they sent for me. So I too came to this country on a ship arriving in Southampton. And when I arrived, I was 7 years of age, and this was a journey of hope and fun and looking forward to a new world, despite the very, very foggy weather as it was then. And if anybody remembers those days, and you're too young to do that, this country was very, very foggy and cold. So this notion of me coming, I was imagining, even as a 7-year-old, what the future would be with my parents in this country. And whilst I was here, I did all the things that you would do. You go to school, you go to university, and then I joined the NHS as a management trainee. And joining the NHS management as a trainee was a challenge. Why was it a challenge? Well, in part, it was because I was in something called the less than 1% club. So the less than 1% club was that I was the first African Caribbean chief executive in the NHS. And don't forget, the NHS in this country is the biggest employer, and if you look at it globally, probably apart from the Chinese army, it is a really big employer. So being less than 1% of leaders from colour was an issue. So I spent 35 years dealing with a number of challenges, but felt very privileged and honoured to be serving the communities that I served. So what were some of those leadership challenges that I experienced? I'm going to focus on one which is relevant to the conversation about sickle cell, which I will tell you a little bit more about in a moment. But there are a number of challenges, but the most latent one was this issue of race and racism and prejudice. And that was the biggest challenge as being part of this less than 1% club. And that is very much for leaders, chief executives or board members. If, you know, for doctors, there was a different type of racism that played out, and in those days getting consultant roles or getting senior nurse leadership roles were challenges. But for a chief executive like me, the biggest challenge was managing and navigating those challenges about race. And I'll come back to how that is relevant to sickle cell. So, before I give you some numbers, let me just talk about what sickle cell is in very, very simple, plain English. It's a genetic blood disorder. That's why, as a charity, we call it a genetic blood disorder. What happens is that everybody has a round blood cell, and that round blood cell carries oxygen all over one's body. With sickle, it's like it says on the tin. It's a sickle shape, it's sticky, and it gets stuck in those blood vessels. When it gets stuck in those blood vessels, there is actually no oxygen going to wherever it's stuck in the body, and that causes significant pain. And when I say significant pain, it's not pain that you say, well, I'll take a paracetamol for that. People that I know say it's like somebody hammering a nail into their joints. And if you're a child with sickle cell, you'll have had a silent stroke by the time you're 12, at least one silent stroke by the time you're 12. So there are 18,000 people, we say that's a minimum, 18,000 people living in the UK with sickle cell anemia. There are well over 500,000 who are very healthy carriers of the sickle cell trait. So that means that they carry the gene, but they're perfectly healthy and lead normal lives as everybody else. 2 people who have trait or carriers, they then have a 1 in 4 chance for every pregnancy of having a child who will have sickle cell anemia. And it's always a 1 in 4 chance. There's no maths or computation that will change that. It's always 1 in 4. And the other really important message about 2 people as carriers is that we as a charity deal with people who say, well, it can't be my side of the family, it must be your side of the family. You know, everything is well, but it's 2 people who create a child with sickle cell anemia. There's 17 million worldwide, so think of this for a moment, and I'll come to race in a moment, but just think that sickle cell is classed in the NHS as a rare condition, but it's the biggest rare condition in this country. So in this audience, I'm sure many of you will know of cystic fibrosis. And cystic fibrosis is a like condition, so it's a genetic condition. It has significant challenges, just like sickle cell. And that is less in terms of numbers than sickle. So sickle cell is the biggest genetic blood condition in this country, but the most underfunded. So that's the position worldwide. The globe is really just to reflect to you that people often associate sickle cell with people from Africa, the Caribbean, that's with heritage, that's the people who get sickle cell. Well, actually, if you look worldwide, the Middle East, Brazil, Europe, so all of Europe, Holland, France, Portugal, the Middle East, so it is truly a global condition. So the importance of that is if you go to places in Europe like Greece or Cyprus, their sickle cell numbers are growing and high. So one of the messages about sickle cell is that it is truly a global condition that affects different ethnicities and not just people who are from Africa or the Caribbean. And just one final fact, the numbers are small, but today 1 in every 300,000 white UK births is a white child with either sickle cell anemia or a carrier. So the dynamics of the population is changing. So it's a really big condition. This is just to say, so I mentioned the severe pain that people get with sickle cell, and it's unpredictable, so it can happen at any time when you get a sickle cell crisis. It could happen at any time, and there are triggers for that. But this slide is really to illustrate that it's also a multi-organ condition. So it is not only pain that you get from living with sickle cell, and pain results in you going to hospital most of the time. When you go to hospital, the way that pain is treated is with morphine, ketamine, and treatments that you can't get in the local chemist. Now, going back to that issue of race, we get and deal still today with many young black men and women who have crisis and are in pain. They look just like me and you in the audience, and they're told, you're not really in pain, you're only here because you want another hit of morphine or ketamine. So the judgment of healthcare professionals in relation to dealing with sickle cell in hospital for crisis is significant. But this slide is to say that it is truly a multi-organ. What it does is it damages the organs over the years. So all of the organs in the body. Those are the main ones I've highlighted in this slide. But actually, the result of sickle is that you lose 20 years of your life compared to somebody who hasn't got sickle cell. So imagine for a second, what is there to treat this condition, which, remember, is the biggest condition in this country, biggest blood disorder in this country? Well, the National Institute of Clinical Excellence has 2 licensed treatments for sickle cell. They're treatments that reduce crisis, the regularity of how you have crisis. So 2 licensed treatment for a condition that has been known about well over 100 years. People have won Nobel Prizes for working out the genetics, but yet there's only 2 licensed treatments. So I give you the example of cystic fibrosis because cystic fibrosis largely affects the Anglo-Saxon population. And the number of licensed treatments for cystic fibrosis is well over 100. So you have 2 for sickle cell, and you have hundreds for cystic fibrosis. So, as I say, that's not a slight on cystic fibrosis, but it's a reflection of sickle cell being underserved, and some of that underserving has been to do with the fact that it affects mainly a certain group of people, both in the UK and globally. So what are the solutions? What are the solutions? If we're imagining what is going to make a difference, then it is about work that we do and you do about raising awareness of sickle cell. So one of the examples, the number of people who go to universities with sickle cell, but if they're ill, catching up on their studies is a challenge. So one of the challenges about sickle is that it can affect your educational attainment if you are regularly outside of school or regularly missing your university education. So the solutions are about better investment, better awareness, and better education and training. So yesterday I opened a ward in a London hospital for a young man who was 22 who died at that hospital because the healthcare staff, and this is London, not some remote part of the country where there's hardly anybody with sickle, but the healthcare professionals didn't really know how to deal with somebody who had sickle cell. So one of the key solutions is about education and training. So imagine for a moment, because I've been imagining what we can do as a charity to improve the lot for people who live with this condition and their families. So for patients and families, if you have sickle cell, whether you live in the East Midlands, the West Midlands, London, the North West, the level of care you get is dependent on healthcare professionals' knowledge and ability in those areas. And if you accept my point that education and training is lacking, then that creates challenges and can lead to premature death. So for patients and families, what we actually want to see is a consistent level of care for people who live with sickle cell. If you get that consistent level of care, then your quality of life as somebody who lives with that condition will improve. And I mentioned earlier, there's only 2 licensed treatments for sickle cell. So we need a range of more treatments from industry to ensure that there's choice of things that are going to make a difference, including curative options. For the general public, I think it's woeful that the country's biggest genetic blood condition is still unknown in many communities. People don't know about sickle cell or explain what sickle cell is. So for the general public, imagine a situation where people are aware of sickle cell, can support people with sickle cell, understand if somebody's having a crisis or in pain and what that means. So that is the vision for the general public. And for healthcare professionals, what's really important is that there is a consistent level of treatment. A did you know question that if you train to be a nurse, you might be taught about the theory of sickle cell, but you might not ever see a patient with sickle cell in your career. And when you do, as one nurse said to me, actually, I struggled. So for healthcare professionals, imagine a future where they are all trained, and if you are a young person, an old person, a middle-aged person on a ward, you know that you're going to get the best care that you can. So these are the factors of the care that we believe that people should get. It needs to be efficient, it needs to be safe, it needs to be patient-centred. And I have to say, all those things are not evident consistently for people who live with sickle cell. And why is it not consistent? Well, there are reasons it's not consistent, and those reasons link back to what I said earlier about race. So why it's inconsistent is that it's been ignored, and the view has been that this only affects this group of people, so it's not a priority. So that is something that we're going to have to address. And the opportunity of me presenting at TED Warwick gives the opportunity to raise that awareness and also give hope in raising that awareness and resilience. Because let me tell you now, if you live with sickle cell anemia, you have to be resilient and you have to have hope. And on that note, I will conclude it and say thank you very much.